Hello, everyone. Thank you for joining us today on our webinar on the diagnostic approach to a liver biopsy. We are privileged to have with us today Dr. Duan, who is a liver and GI pathologist at University Health Network in Toronto and an assistant professor at the University of Toronto. He's, in addition to his diagnostic work, his research focuses on applying digital pathology and AI tools to improve biomarker testing for both neoplastic and non-neoplastic liver diseases. Dr. Duan, thank you very much for sharing your time and experience with us today, and we look forward to hearing what you have to tell us about liver biopsy interpretation.
Thanks very much for the kind introduction. So I'm going to share my screen now. All right. So for this presentation, I was told to briefly talk about the diagnostic approach to a liver biopsy, and to illustrate this, I have selected just a few interesting cases from my routine practice here in Canada. Here are the learning objectives of this presentation. First, familiarize with common scenarios where you may encounter a liver biopsy. Second, understand the basic approach and review common patterns of liver injury that one may see under the microscope. And then third, review real-life examples of liver pathologies and their treatment implications. So starting off with common scenarios where a liver biopsy may be performed. At our center, most liver biopsies are performed as part of the initial workup for suspected liver disease. However, some of the biopsies that we do encounter are also performed to monitor chronic liver disease, particularly to assess treatment response and stage fibrosis. And in liver transplantation, allograft biopsies are also frequently performed to rule out graft rejection and to adjust immunosuppression. So when thinking about liver biopsies can be broadly divided into two main categories depending on their clinical indication. Targeted biopsies are generally performed to rule out cancer as part of the workup for suspicious liver lesions on imaging. And these biopsies are often suboptimal or inadequate for medical liver assessment due to their proximity to a mass-forming lesion. This is in contrast to non-targeted or random liver biopsies, which are usually performed anyways for workup of suspected medical liver disease, usually in the context of unexplained liver test abnormalities. Now, moving on to liver pathology, this slide illustrates the normal liver anatomy. So as seen here, you can see that the liver is divided into distinct segments where each segment has its own vascular and biliary drainage. And if you look closer at the liver microarchitecture at a microscopic level, the liver is primarily comprised of hepatocytes, as indicated by these red arrows, and portal tract structures, which contain the bile duct and the liver dual blood supply, specifically a portal vein and a hepatic artery. And again, this slide shows an anatomical illustration of the liver microarchitecture. And here is the corresponding histology image of what you would actually see under the microscope. So as seen here, the same anatomical landmarks which were described previously are visualized in 2 dimensions under the microscope. And this slide of normal liver histology is very important to understand because each of these compartments can be injured, leading to very different liver pathologies, each with distinct treatment strategies. So moving on to what is our purpose in liver medicine. Well, this slide illustrates what the lifespan of a normal liver should look like without significant injury or fibrosis, macroscopically and under the microscope as seen here. And ideally, this is what you would want in a normal, healthy liver during the lifespan of a person. Now, in pathologic state, liver injury occurs, leading to progressive fibrosis in the liver. And if injury persists over time, this can lead to liver cirrhosis and its complication. And on this image on the right, you can see an end-stage cirrhotic liver, which was complicated by the development of a hepatocellular carcinoma, which you can see here. This image on the bottom left here shows what a cirrhotic liver looks like under the microscope. So you can see that the grossly nodular liver are also appreciated here under the microscope. And you can use a trichrome stain to highlight the green bridging fibrosis surrounding these nodules. So this is what a cirrhotic liver looks like under the microscope compared to what a normal liver would look like under the microscope. And ultimately, our goal in liver medicine is to stop liver injury and fibrosis through early detection, intervention, and prevention. So moving on now to the diagnostic workup of medical liver disease. There are four main components. Three of these are non-invasive data point consisting of a detailed clinical history, imaging, and laboratory tests that should include baseline liver biochemistry, autoimmune and viral serologies. And in this overall context, a liver biopsy is used to confirm the dominant pattern of injury and rule out other pathologies that can mimic each other clinically, biochemically, and radiologically. When assessing liver biopsies, I like to use the ADC approach, which stands for assess, diagnose, and correlate. So first, I try to assess the liver biopsy without any clinical information and without bias. Second, I try to put the tissue histology findings together to establish a diagnosis on the dominant pattern of liver injury. And then finally, I try to correlate the pathology findings with the patient's clinical, biochemistry, and radiology to ensure that everything is concordant. And with regards to pathology diagnosis, here is a non-exhaustive list of of common patterns of liver injury that one may see under the microscope. So we will now go over each of these briefly using real-life case examples. So starting with case one. Case one is a middle-aged lady who presented with abnormal liver enzymes detected by her family doctor. She describes no symptoms. There's also no autoimmune or family history of liver disease. She denies taking any medications or drugs and only drinks alcohol socially. Her lab tests show mainly a hepatic pattern of liver enzyme elevation with positive ANA and elevated IgG at around 20 around the time of biopsy. Her imaging is unremarkable, but her FibroScan is elevated at 12.2 kilopascal, and all her viral serologies were all negative. So at this point, a liver biopsy was performed for further evaluation to assess for the possibility of autoimmune liver disease. So you can already see at low power here that there is portal inflammation. And on medium and high power, you can see that the inflammation extends beyond the portal tract into the lobules. So there is active interface hepatitis as well as obvious inflammatory damage around these hepatic veins. And on closer inspection, you can see that the inflammatory infiltrate is rich in plasma cells, which are highlighted by these red boxes. And there's also accompanying hepatic fibrosis, which is highlighted in green here on this trichrome stain, which confirms the chronic nature of this immune injury. So taking all of these histologic findings, what do you think is the diagnosis here? I will just give you a couple of seconds to think. So as you may have suspected, the diagnosis here is that of a severe immune-mediated hepatitis. And in this clinical context, the biopsy findings are consistent with autoimmune hepatitis. The overall amount of fibrosis was actually mild on the biopsy, indicating that the FibroScan measurements were likely confounded or inflated by active inflammation around the time of biopsy. So following the biopsy, the patient was started on immunosuppression in the form of budesonide. And as you can see here, the patient's autoimmune hepatitis responded biochemically to the budesonide, and the patient was subsequently started on azathioprine. So a follow-up FibroScan after normalization of her liver enzymes indeed confirmed the F1 fibrosis, which was detected on the pretreatment liver biopsy. Her budesonide was subsequently reduced and stopped, and the patient's liver enzymes remains normal at 2-year follow-up on azathioprine monotherapy. So this is a very classic case of treated autoimmune hepatitis. Now, moving on to other examples of immune-mediated hepatitis. So here is another patient's liver biopsy showing an immune-mediated hepatitis featuring portal inflammation with interface hepatitis and lobular inflammation. You can see that on the trichrome stain, there is also hepatic fibrosis, which is consistent with a chronic hepatitis. And on closer inspection, you can see that some of these hepatocytes demonstrate a homogeneous granular eosinophilic cytoplasm, which we refer to as ground glass cytoplasmic changes in hepatocyte. And so if you perform immunohistochemistry here, you can see that there is strong positivity for hepatitis B surface antigen, and that the ground glass appearance is actually due to proliferation of smooth endoplasmic reticulum and accumulation of intracellular hepatitis B surface antigen. So therefore, the final diagnosis here is that of a chronic viral hepatitis B. Here is another example of a patient with hepatitis. So on low and medium magnification, you can appreciate that there is portal inflammation and lobular inflammation consistent with a hepatitis. And on closer inspection, you can see that there are these occasional microabscesses featuring enlarged hepatocytes with nuclear inclusions surrounded by neutrophils. So as suggested by its name, this histology is classic for cytomegalovirus hepatitis, or CMV, which can be also confirmed by immunohistochemistry as shown here. Moving on to another example of a liver biopsy with immune-mediated hepatitis. So this is a patient with a liver biopsy that shows both steatosis as well as this inflammatory infiltrate. You can see that the inflammation extends beyond the portal tract with interface hepatitis and lobular inflammation. Additional immunohistochemistry shows that the hepatocytes are positive for hepatitis B surface antigen. And because of the sinusoidal lymphocytosis, in situ hybridization for Epstein-Barr virus encoding region was also performed here and was positive and scattered lymphocytes. And so taken together, the biopsy confirms that this is actually a hepatitis due to hepatitis B and Epstein-Barr virus co-infection. So this is a nice case that serves as a reminder that multiple viral etiologies can rarely coexist in cases of hepatitis. The last case example that I wanted to discuss today is a middle-aged man with metastatic cancer who was treated with nivolumab, which is a immune checkpoint inhibitor. He developed severe transaminases, which was clinically consistent with grade 4 immune checkpoint inhibitor hepatitis. This was treated with high-dose oral prednisone, followed by IV methylprednisolone and second-line tocilizumab. And despite second-line treatment, the liver enzymes continued to rise, at which point this liver biopsy was performed for further assessment and the possibility of treatment escalation. So as you can see here, there is severe portal and perivenular inflammation with areas of bridging necrosis, which you can also appreciate on the trichrome stain. And in contrast to the previous case examples, you can see that there is no obvious green staining to indicate significant fibrosis. So overall, the biopsy findings and the clinical context are all consistent with the severe acute immune-mediated hepatitis due to checkpoint inhibitor therapy. And this patient ultimately required as treatment escalation to plasma cell exchange therapy, which resulted in an excellent and sustained biochemical response. Now we're going to move to a different area of liver pathology. And case 2, actually, as you can see here, looks very different. This is a middle-aged lady who has a history of hypertension, dyslipidemia, and prediabetes, as well as some abnormal liver enzymes with slightly higher ALT compared to AST. And because of her FibroScan was elevated at 23.4 kilopascal, this liver biopsy was performed for further evaluation. So as you can see here, this looks very different from our previous cases of immune-mediated hepatitis. The main findings here are hepatic steatosis with these enlarged, swollen hepatocytes known as balloon hepatocyte. And ballooning degeneration is the histologic hallmark of active steatohepatitis. This is usually accompanied with lobular inflammation and this very classic pattern of fibrosis, which is often referred to as chicken wire or pericellular fibrosis on the trichrome stain. So as you might have guessed, the pattern of injury here is steatotic liver disease with active steatohepatitis. And this slide illustrates the main etiologies of steatotic liver disease, with the most common causes being metabolic dysfunction associated steatotic liver disease and alcohol or a combination of the two. Now, there are also less common etiologies of steatotic liver disease, which should be considered separately due to their distinct pathophysiology. These include drug-induced causes of steatotic liver injury, as well as certain monogenic diseases such as Wilson disease and inborn errors of metabolism. So as you may know, MASH, or metabolic dysfunction associated steatohepatitis, is now a treatable liver disease. And this recent New England Journal of Medicine paper reported the phase 3 trial showing significant benefit of GLP-1 receptor agonist in patients with MASH and F2 or F3 fibrosis compared to placebo. And this landmark study is what subsequently led to the FDA approval of Wegovy for the treatment of MASH in adults with moderate to advanced fibrosis. And going back to our patient, which we showed the biopsy previously, following the biopsy results, which were consistent with MASH F3 fibrosis, the patient was enrolled into a GLP-1 receptor agonist clinical trial at our center, which led to gradual improvement of both this patient's liver biochemistry, but also FibroScan measurements. So moving on to other causes of steatohepatitis. As mentioned previously, alcohol is another common culprit of liver steatohepatitis. Here is an example of a liver biopsy in a patient with known alcohol use disorder. So you can see again the steatosis with these balloon hepatocyte, lobular inflammation, Mallory bodies. The trichrome stain again showed this very characteristic chicken wire or pericellular pattern of fibrosis around these balloon hepatocytes, which is often associated with lobular inflammation. And although not specific in isolation, neutrophils surrounding balloon hepatocyte, which is sometimes referred to as neutrophil satellocytosis, is more commonly described in the context of alcohol compared to NASH. Moving on to monogenic diseases associated with hepatic steatosis. Here is an explanted liver with cirrhosis, which you can see under the microscope here on this trichrome stain showing the bridging fibrosis with distorted nodular architecture. On higher magnification of this area, you can see that there is hepatic steatosis and numerous balloon hepatocytes. And in this particular case, the rhodonine stain highlights toxic copper accumulation, which appear as orange or red-brown granules within hepatocyte. Therefore, this was a case of cirrhosis secondary to Wilson disease, which was also confirmed by genetic testing of the ATP7B gene. Moving on to other genetic and metabolic liver disease, here is another patient's liver showing these two distinct foci of HCC, which you can see here under the microscope on the right-hand side, on a background of liver cirrhosis. So you can see on this trichrome stain that there's bridging fibrosis with distorted nodular architecture, which was also apparent on the gross image. And in this case, a PSD stain of the background liver highlights abnormal alpha-1 antitrypsin accumulation within the hepatocytes, as shown nicely here by this red arrow. And therefore, this was a case of multifocal HCC arising from cirrhosis due to alpha-1 antitrypsin deficiency. And this was confirmed genetically to be of the PIZZ genotype. Here's another case of a cirrhotic liver with multifocal HCC. You can see the microscopic images of the distinct HCC foci here on the right-hand side. Again, this is the trichrome stain of the background liver showing the bridging fibrosis with distorted nodular architecture. But in this case, what was different is that the iron stain showed severe hepatic iron overload as demonstrated by these coarse blue granules within the hepatocytes. So in this case, the diagnosis was that of multifocal HCC arising from cirrhosis secondary to hemochromatosis, and genetic testing later confirmed this to be HFE gene-related hereditary hemochromatosis. So moving on now to another liver biopsy Image here on the left-hand side shows this patient's liver biopsy, and the trichrome stain shows that this is an advanced stage liver disease with bridging fibrosis and distorted nodular architecture consistent with cirrhosis. And what will catch your eye even on the H&E stain is these broad areas of hepatocytes with cytoplasmic clearing. And if you go on higher magnification, you can better appreciate the cytoplasmic clearing. An additional PAS and PASD stain can be used to confirm the abnormal glycogen accumulation, which is completely digested on the PSD stain with diastase, which confirms the glycogen nature of this cytoplasmic clearing. So this is a case of glycogenic hepatopathy, and further genetic testing confirmed a diagnosis of glycogen storage disease type 3 caused by mutation in the AGL gene, encoding the glycogen debranching enzyme. Here is the last case example of a metabolic liver disease that I wanted to present at today's section. Clinically, the patient presented with thrombocytopenia, hepatosplenomegaly, and portal hypertension. The trichrome stain here on the left-hand side shows preserved liver architecture without cirrhosis. However, on the H&E, you can see at higher magnification the presence of these pale staining cells infiltrating through the liver, which is obviously an abnormal finding. And if you do additional stains, you can see on the trichrome stain that these pale staining cells are present within sinusoid with accompanying sinusoidal fibrosis, likely contributing to this patient's portal hypertension. And on the PSD stain, you can see that these cells have abundant fibrillary cytoplasm with characteristic wrinkled tissue paper appearance, which is consistent with Gaucher cell. And so subsequent genetic testing confirmed this to be Gaucher disease type 1, and the patient was started on enzyme replacement therapy. Now moving on to case 3, this was a middle-aged lady with cholestatic liver enzymes. She also had elevated IgG and IgM. Her imaging was unremarkable, and therefore a pretreatment biopsy was performed. And while waiting for the biopsy results, the patient was empirically started on UDCA and prednisone for suspected PBC autoimmune hepatitis overlap. So as you can see here, she initially had a good biochemical response. However, ALT started to climb again, even on prednisone. So this is the pre-treatment liver biopsy. At low power, you can already appreciate that there is marked inflammation centered mainly around the portal tracts. And on higher magnification, you can see the classic florid duct lesions with granulomatous inflammation surrounding this bile duct. And this is the hallmark feature of active primary biliary cholangitis. So following review of the pre-treatment biopsy, which was consistent with PBC without significant features of overlapping autoimmune hepatitis, prednisone was tapered and stopped, and the patient was switched to triple PBC therapy, which you can see here, with subsequent sustained long-term biochemical response as demonstrated in this graph. So this is a classic case of a more inflammatory PBC phenotype that required triple PBC therapy to normalize for liver enzymes. Here is another patient's liver biopsy, which shows a very different pattern of biliary injury. So in contrast to the last case, which was very inflammatory, you can see that the main finding here is the presence of these periductal onion skin concentric fibrosis, which are shown by these red arrows, and this is the histologic hallmark of sclerosing cholangitis. These foci of periductal concentric fibrosis can be nicely highlighted on the trichrome stain as shown in this biopsy. And if you look closely and get lucky, you can also sometimes see these fiber scar, which are completely replacing a lost bile duct, which is a very classic feature of primary or secondary sclerosing cholangitis. Here is another example of biliary pathology. So in this patient with clinically suspected drug-induced liver injury and cholestatic pattern of liver enzyme elevation, a liver biopsy may sometimes be performed to assess for vanishing bile duct syndrome. On histology, the typical finding is these portal tract, which contain an artery and a vein, but no bile duct, and the presence of ductopenia or loss of intrahepatic interlobular bile duct is supportive of the clinical diagnosis of vanishing bile duct syndrome. On the right-hand side, I've just included a list, non-exhaustive list of drugs that are commonly associated with vanishing bile duct syndrome, with antibiotics, particularly amoxicillin and clavulanic acid being one of the most frequent offenders. The last case of biliary pathology that I wanted to present today is a middle-aged man who is post-liver transplant and presented with cholestatic liver enzymes. And because the imaging, including CT scan, were all unremarkable, a liver biopsy was performed. Here is the liver biopsy. You can see obviously that the liver biopsy is abnormal. The main finding here is the presence of portal inflammation with edema and neutrophils along with ductular reaction. And this appearance is highly suspicious for a mechanical biliary issue. So following review of the biopsy, an urgent MRCP was performed, and despite the negative CT scan, the MRCP did reveal focal biliary narrowing. The patient subsequently underwent ERCP, which confirmed the biliary stricture, and he was successfully treated with stent placement, resulting in normalization of his liver enzyme, as shown in this graph. So moving on to case 4, this was a middle-aged woman who presented with abdominal pain and ascites. Her liver biochemistry showed mainly a mixed pattern of liver enzyme elevation, but more cholestatic than hepatic. And the imaging revealed abnormal liver morphology, which raised the possibility of decompensated cirrhosis, which prompted this liver biopsy. So you can see that this liver biopsy is obviously abnormal. There, on the trichrome stain, you can see that the liver is not cirrhotic. There is mild fibrosis, but there's no evidence of cirrhosis. And on higher magnification, you can see that there's marked sinusoidal dilatation and congestion with hepatocyte atrophy as highlighted by this red arrow. So as you might have suspected here, the findings are characteristic of acute severe congestive hepatopathy. And following review of this liver biopsy, additional imaging was performed, which identified a hepatic vein thrombosis, and the patient was promptly started on anticoagulation. Now, the reason why it's important to pick up these cases early is that chronic untreated congestive hepatopathy can progress to congestive cirrhosis and end-stage liver disease. So this is an example of a patient's liver biopsy with end-stage congestive hepatopathy. In contrast to the previous biopsy, you can see that there's sinusoidal congestion, but at this point, there's distorted liver architecture. And then when you perform a trichrome stain, you can see that this liver has developed severe bridging fibrosis with severe sinusoidal fibrosis around these dilated sinusoids, as well as formation of distorted nodules. So this patient ultimately progressed to end-stage liver disease and required liver transplantation, which is what we're trying to prevent. Moving on to the fifth pattern. Case 5 is a middle-aged man who presented with jaundice, nausea, and malaise. He had preceding sore throat and fever and had been taking an undisclosed amount of Tylenol. His laboratory results showed AST and ALT of nearly 6,000, with bilirubin of over 200 and an INR above 10. The imaging revealed abnormal liver morphology, and the possibility of decompensated cirrhosis was queried, and a transjugular liver biopsy was performed, as you can see here, for further evaluation. So you can see that the liver is obviously abnormal, and on high magnification, the first thing that should catch your eye is the complete absence of hepatocytes and entire lobules that have been replaced by inflammation and this ductular proliferation. Corresponding trichrome stain shows that these areas of parenchymal extinction and collapse stain pale on the trichrome stain compared to the bright green staining of normal hepatic vein connective tissue. And so this is a classic case of severe hepatic necrosis with parenchymal collapse, which can sometimes mimic cirrhosis radiologically. Here's a study that looked at common etiologies of acute liver failure, which is often the clinical correlate of massive hepatic necrosis. So common etiologies of acute liver failures in the United States include acetaminophen, which was the suspected culprit here, as well as other drugs. Autoimmune hepatitis is another common cause, and acute viral hepatitis, particular hepatitis B. And at our center, we do encounter a number of these cases every year requiring urgent liver transplantation. So here's another example of an explanted liver from a patient with acute liver failure. So you can see even at low magnification that there is complete massive hepatic necrosis with no residual hepatocytes. I've just included an image of what a normal liver should look like with abundant hepatocytes, which are absent in this patient with acute liver failure. So the corresponding trichrome stain shows no significant fibrosis. Again, the absence of green staining is entirely consistent with acute rather than chronic liver failure. And in this particular case, EBER in situ hybridization was positive, confirming that this was actually a rare case of EBV-associated acute liver failure. In a 2015 study, primary EBV infection accounted for less than 1% of adult acute liver failure cases in the US, but is associated with high fatality rate. Here is another rare cause of acute liver failure that is usually fatal if left untreated. So the image on the left here shows the H&E section of the liver biopsy, which demonstrate these areas of geographic necrosis. The image on the right here shows hepatocytes bordering these areas of necrosis with nuclear features of margination and molding. So if you perform immunohistochemistry here for HSV, this was positive, confirming a case of herpetic hepatitis, which can frequently present with hepatic necrosis. And in this case, the patient was promptly started on antiviral therapy. Now, for the last few minutes, I'm just going to move on to the last pattern of injury that we described previously. So here is a patient, a middle-aged man who presented with 2-week history of malaise and jaundice. He was previously healthy and active, and his lab results showed predominantly a cholestatic pattern of liver enzyme elevation, with otherwise normal platelets and INR, negative viral and autoimmune serologies. His CT scan revealed new moderate volume ascites with no vasculability or mass-forming pathologies. And because of the cholestatic liver enzymes, He also underwent both MRCP and ERCP, which were both normal. And given all the negative investigations, he was um, he was referred for liver biopsy for further evaluation. So you can see that this is obviously an abnormal liver biopsy. And the main finding here is diffuse sinusoidal deposition of this pink amorphous material with accompanying hepatocyte atrophy. And this histologic appearance is classic for hepatic amyloidosis. As you might have guessed, we're now in the umbrella of infiltrated liver disease, where liver parenchyma is progressively replaced by abnormal constituents, which can be neoplastic or non-neoplastic, which often leads to the clinical finding of hepatomegaly or abnormal liver enzymes, commonly in a cholestatic pattern. So in this particular case, proteomic analysis was also performed and confirms amyloid deposition of lambda light chain type. And following the liver biopsy, a bone marrow biopsy was also performed showing a lambda restricted clonal plasma cell population, and this patient was subsequently started on sideboard chemotherapy. Moving on to other examples of infiltrated liver disease. So here is a liver biopsy in a patient with known sarcoidosis. On higher magnification, you can appreciate these very nicely formed non-necrotizing epithelioid granulomas, which are consistent in this clinical context with liver involvement by sarcoidosis. Here is the corresponding trichrome stain showing significant hepatic fibrosis, which can occur in association with chronic granulomatous inflammation. Here's another case example to remind ourselves that infections should always be considered in the differential diagnosis of hepatic granulomas. So in this case, you can see that these arrows highlight the numerous schistosoma eggs within a portal tract. And interestingly, this case of schistosomiasis was diagnosed incidentally in a liver resection specimen for cancer metastasis. Here is another example of an infection which can present with granulomatous inflammation. So you can see here the middle image shows the granulomatous inflammation, while the image on the right shows the nicely laminated membranes. And if you do a silver stain, you can see that these membranes stain strongly positive with GMS stain consistent with an echinococcal cyst. And in this case, PCR testing was also performed, which confirmed alveolar echinococcus caused by the tapeworm Echinococcus multicularis. And this condition carries a particular high rate mortality rate if left untreated and can mimic hepatic malignancy on imaging. So here's another case of alveolar echinococcus that we published, which simulated a large aggressive hepatic tumor on imaging. These are some intraoperative image which demonstrate how the tapeworm can infiltrate liver parenchyma, mimicking a neoplastic process. And I'm just going to finish my presentation with this final case of infiltrated liver disease. Obviously, tumor is always what we're concerned about. And in this case, higher magnification of the liver biopsy shows these epithelioid tumor cells arranged in a fibrostroma. The classic and most helpful finding is the presence of these intracytoplasmic lumina, some of which contain red blood cells, a classic finding for this diagnostic entity. So additional ancillary stains show that the tumor stained positive for vascular markers, ERG and CD34 by immunohistochemistry, and further testing by next generation sequencing confirms a WWTR1 CAMTA1 gene fusion, which confirms the diagnosis of epithelioid hemangioendothelioma. And in our experience, epithelioid hemangioendothelioma of the liver can be quite aggressive and should warrant prompt clinical intervention. And here's a gross photograph of a liver with widely invasive epithelioid hemangioendothelioma that